Welcome back to Care Transitions Today. This is a healthcare podcast presented by the American Case Management Association. I'm your host, Deb McElroy. Before we begin today, we have just a brief message from the American Case Management Association. Join your peers at the 2021 ACMA National Conference, June 22nd through 25th in Orlando. You can engage and learn with case management and transitions of care professionals from across the country at this premier event. The conference offers a lineup of healthcare experts presenting sessions designed to improve patient care outcomes and prepare attendees for success in this ever-changing healthcare system. Learn more and register at casemanagementconference.com. That is casemanagementconference.com. Today, we are going to focus on the implementation and development of a case management clinical ladder, which I know will be of interest to a lot of you. This topic and our speaker won the most innovative poster presentation at the 2019 National ACMA conference. I am delighted today to have joining us Kathleen Bellamy from the Arthur James Cancer Hospital at The Ohio State University Wexner Medical Center. And welcome, Kathleen.
Thank you. Thanks for having me.
I'm going to give folks just a little bit of your background, but then hop in as we start. You've been an inpatient case manager at Arthur James Cancer Hospital at OSU for almost 28 years, and I know your expertise is case management of patients with head and neck cancer. So
correct.
That's a little bit of background I have. Can you tell us a little bit about that role?
I've been in that role for, like you said, for a long time, and I've really gotten a chance to sort of watch that whole service line develop, and things that we were doing discharge planning wise and resource connection wise were very different many years ago. And most of my role now is doing connections with resources, discharge planning, but also the utilization review piece. We do our own utilization reviews in our case management role. And also we're involved in programs and activities in the hospital. So we do research and we do implementation of pathways. Currently, we're working on an ERAS protocol for patients who are going into the free flap surgeries so that we can streamline each day-to-day process, knowing exactly what happens, physical therapy, occupational therapy, what meds people are given on certain days, so that we can make sure that people are getting the best care and quickly. So
that's great. That's great. Thank you.
Sure.
As I shared with you, I think before, that's something near and dear to my heart, a role that I had a similar role in the past. So
yeah.
What we're going to talk about today, the innovation, I know this is of high interest to folks as you're looking at the evolution of how our case management departments operate. So can you talk about the decision to develop and implement a case management clinical ladder program, and just what did you base your model on, and what does that look like?
Sure. Clinical ladders have been around in nursing since the 70s, and most of those tended to use a framework that was based off of Patricia Benner's work with moving from novice to expert, and it allowed staff nurses and other nurses in the hospitals to, be rewarded for extra projects or extra education, and it increased staff retention and employee autonomy. And there was data to suggest that it was an overall benefit to the system to have these types of ladders in place. So as our department started to get bigger and we had more nurses that were in other roles joining our department, we realized that we were missing that that benefit that they had in other roles where they could, take risks and do research or try to write a chapter for a book. And having a ladder program allowed nurses to do that in a place that was supported by leadership and the hospital system. So back in, I think, 2012, our department thought, well, one of the ways that we can try to, support the new staff in our department was to begin creating a clinical ladder program just for our case managers. So we formed a small committee in the department, and I think there were about maybe 8 to 10 case managers, along with some leadership representation, to really sit and focus on what our goals were and what our expectations were, and kind of do a needs assessment of the case managers at the time. So, what would you like to see out of a ladder program? Had people been involved in a ladder before, and kind of spending some time figuring out what it was we wanted to build. And then after we did that, we kind of went and tried to look into the research and say, okay, how can we make sure that this is evidence-based? How can we make sure that this is cost-effective? How can we make sure that we're going to put all this energy into something and it's going to be successful? So we looked at, first the literature, and there was a lot, and there's a lot of information about clinical ladders in general. It's a tremendously rewarding and inventive system that has proven to show benefits. But there wasn't any one that was really specific to the case management role. And while some of the ladders could be transitioned or maybe used that were specific to floor nursing, there were several things that weren't going to work. Most floor nursing or a nursing system clinical ladders, you maintain that level once you get it. And, there may be an hourly, your reimbursement or your benefits or bonus would be hourly. And that might not work with us because some case management departments are salaried. So we had to kind of work on that. So we thought, well, let's try to call around. So we reached out to other academic medical centers to see if their case management departments had clinical ladders in place. And almost all of them, all of them, we couldn't find anybody that had an implemented case management clinical ladder program. But everybody that we talked to said, oh, that would be great. Our case managers would love that. So clearly there was a need for it. We just couldn't find anybody that had a framework in place. So what we did was we went to other disciplines within our hospital system, within the James Cancer Hospital, but also within Ohio State University Medical Center. So we looked at clinical ladders in place for floor nursing or for staff nurses. And then we looked at there were clinical ladders in place for respiratory therapy, for physical therapy, for physician assistants. And so we looked at their work and decided to sort of pick and choose what was working with them. And we talked to other people in those departments that were participants in their ladder programs to see what was working and what was not working. And we were fortunate enough to, at the same time, with our department is the case management department contains case managers, but also our social workers. And simultaneously, the social workers were working on a clinical ladder program too. So we could share information. And while our ladders are not the same, we kind of could use the same steps.
Can I ask you a question about that? Because
Yes,
it's a question that I've heard come up. There are organizations where the social workers and nurses are both functioning under a similar role in terms of scope and responsibility as case management staff. I just want to level set. In your organization, it sounds like it works a little bit different.
There are very clear role differentiations between our social workers and our case managers.
Right.
We are, our model is that we are assigned by disease it's disease specific. So for instance, we have a social worker on head and neck oncology who works just with head and neck patients. And so, breast cancer patients in the outpatient setting would have a social worker and a case manager. The heme services would be divided by service. Gynecological cancers, ortho-surg, all those disease models work together so that they can really become the experts at the same time. And you're always working with the same people, and the physicians are working with the same two people in terms of getting people out of the hospital and getting them through the system. So, but it is very clear in terms of what our roles are. There's not a lot of ambiguity. It's pretty clear.
That's great.
If that makes sense.
So I just want to add that additional clarification because I think this is of interest to folks. So you're the social workers have a clinical progression ladder that is aside from the one that you are talking about today.
Correct. Because their goals and their tasks would be different, or would want to be different, and so we felt, and they were working on theirs separately. So we really only kind of went back and forth in terms of information sharing and that kind of stuff. We didn't need to present them together to the hospital to get approved, or they're really completely separate entities. They go by a different scoring model, so they're different. But in terms of the general framework, there are some similarities.
Great. So yeah. Can you talk about, so you started in 2012.
Yeah.
And timeline wise, when was the full implementation, or when did you pilot? How did that progress?
Well, it took a long time because back in 2012, one of the main driving factors behind people wanting to participate in a ladder program was to make sure that it was funded and that there was a financial reward associated to your movement through the ladder. And so at that point, once we kind of got some idea of what we wanted to have in place, we needed to bring in somebody from human resources to say, what is possible, what's doable, what can we continue to fund as people want to join this program? Because it wasn't going to work if we couldn't have a financial component to it. And so we really felt like we needed to make sure that was in place before we moved any further. The leadership and human resources sort of did that. I was just a case manager, so I'm not exactly sure what happened between those two entities. But we did get funding, and we came up with a financial reimbursement schedule that seems to work and certainly promotes people to join. But it was 2 years before it. From conception to implementation, it was a good 2 solid years before we got it ready for people to enroll. And that, you can get a framework in place, but you kind of don't realize how specific you have to be. I mean, you have to have all your T's crossed and your I's dotted to get it to work.
And who out of your department works on that? Like, who has oversight and that kind of thing? You've talked a lot about external partners that you went to as resources, and certainly your very close colleagues, the social workers, helped inform that. But as it's evolving and you're doing quality improvement, who gets involved with that?
We have a leader, mostly the managers and the director of the department make up the leadership team. They're the people that review the final submissions of people's clinical ladder projects. And they're the ones that are the ultimate decision makers in terms of what projects are acceptable and what are improved. As we go through, each year, things become clear that weren't working, and leadership goes back and makes changes. And usually every year there's some additions and changes to the document or the process. And leadership makes sure that they're the ones driving that. And they ask for our feedback. It's not that they're a one-man show, but or one-person show, but there is a management team that formulates the clinical ladder review committee, and that's where most of those decisions are made.
So, can you talk in broad strokes about what you think has gone really well for the program? And you talked about some things that you probably dropped or modified, like any lessons learned as you're...
Yeah, there are a lot. I think right out of the gate, the very first thing that we had to do was to get people to try to do it. We were going in blind, in 2014. In 2014, we had 4 applicants to the program. Now, we have a pretty big department. Back in 2015, so 14, 15, we had, 96, between 50 and 100 case managers in the department. So of that number, only 4 of them, applied to enter the clinical ladder program. So, right at the beginning, it was really kind of getting people involved in the program and trusting them, or having them trust us, to take the risk to join. Because when we first started, it was all paper, it was an actual document that was handed to people, and you wrote things on paper and you printed them out and you created a binder of all of your documents and you handed all of that stuff to the leaders to review and to grade and to give feedback on. Now, however many years later, all of this is streamlined. It's all online. So it's all electronic. So when you're looking at doing a clinical ladder at the beginning, it seems just daunting. It just seems like an unrealistic task to think about, okay, in the next year, I'm going to write a chapter, or I'm going to create a poster at a national conference, or I'm going to do a DMAIC study to try to see how to reduce length of stay or something like that. It really is a big risk to kind of set yourself out there and present those goals to the department and say, this is what I'm going to do. And so one of the things we had to do was kind of just bring people in and have them share their story. So after we had 4 applicants, all 4 of those passed. We apply at the beginning of the year. You submit a request to join the ladder. Your manager or director has to sign off and saying that you're in good standing, that you've I think you need to be here. You need to have been in our department for 2 years. And so someone signs off and says, yes, you can do it. And then you basically have 1 calendar year to get your projects done. The other lesson that was very clear was about probably 1 to 2 years in, we realized that people needed to have a mentor. They needed to have somebody who they could go to bounce ideas off and say, look, I'm having a hard time with this project. And we were such a new entity that we didn't realize that at the beginning. So everybody was kind of working it out and figuring it out. And we realized that people needed to have someone to bring their concerns to and their questions and their fears. And so as people started to pass and become a case manager to, or be successful in the ladder, we asked them if they wanted to become a mentor. And so we have a mentorship program where new clinical ladder applicants are assigned or can choose a mentor, someone who's been through the program before, to provide that feedback. And it's one of the nicest things I think about the program is because, you can have this grand idea about a project or a concept, and it seems really great on paper. And then when you actually try to put it into work, you run into something that isn't working. And you can sit down with your mentor and say, okay, this is the problem I'm having. And they can give you honest feedback and say, I think this is good, but why don't you try this? Or why don't you try that? And so that's nice. And we also realized that it was very hard to get a timeline in place from looking at a paper ladder. It was hard to kind of get a an outline in terms of what you needed to do time-wise throughout the year. So we went back and created a timeline for people to say, look, this is where you should be, by April, by May. This is when you need to think about doing this. This is when you should start writing up things. This is when you should start doing this, because what we didn't want to have happen is to have people take on this task or this opportunity and then not know that they needed to be working on it all year long. And then all of a sudden it's December 1st and they may have had some things done, but they just can't get it all written up because time got away from them. So we did go back and put a formal outline, like a model to go by that gave people some idea of where they needed to be at what time during the process. But we didn't kind of know that at the beginning.
Yeah. So you talked about, that first year and for people, what does that look like today?
Oh, well, I mean, it's much more clear because we do have, the mentor in place and we do have the framework, but it is the first year that you do it. You can still see people, kind of feeling like maybe they bit off more than they could chew. I mean, one of the things that we needed to do when the department agreed to fund it was to make sure that that this was a robust and challenging program. We didn't want it to be something that was easy. We didn't want it to be something that didn't mean anything. We wanted to make sure that the projects had a level of difficulty that would be evident in reading it. We wanted it to be programs that would help the department or the hospital or a service line or the community. We needed it to be a very meaningful program for people to be involved in and to complete, because we were financially backing it. So we needed it. We needed to make sure that we could prove that the money we were spending was worth it in these areas.
And how many people do you have involved in the program?
So we started in 2014 with 4 applicants, and we kind of increased, 1 to 2 throughout the years. And in 2020, we had 12 applicants, and 12 were successful. It was a little bit lower number. The year before we had 16 applicants, but 2020 was a little bit of an unusual year. So we had some people who had some difficulty getting some projects. I mean, just kind of the world kind of changed. So some people were able to continue with the projects that they had set out to do, and other people couldn't do it and withdrew. We do have a date halfway through the year where you can withdraw and there's no penalty, and it's like you never applied. So there were fewer. We have more this year. I don't have the final number for the applicants this year, but we do have more. It's closer to that 16 number. But now we have a department of, we have over 100, I think between 100 and 130 people in our department. So, it's still a small number in terms of our department in general, but it's one that, we're really very proud of, because a lot of people don't have a ladder program where people can, we have case managers who are getting master's degrees, who are getting doctorates, who are, doing a lot of really fantastic work that's technically a little bit outside the realm of their day-to-day job. And we wanted to find a way to reward people for that and to encourage people to take that step and say, I'm going to try to do this research project, or I am going to try to, I think this is something we can do in the department or with our patients, and I want to find a way to do it. And this provides people a safe opportunity to get some support to do it, and also to be rewarded not only financially, but just within our department as somebody who's proven to be to show excellence.
So Kathleen, can you talk about why this is important, and why you think some folks are hesitating to jump in?
Well, I think anytime you tackle something that's scary. People are hesitant at the beginning, but fear is a great motivator sometimes, and having a clinical ladder gives people an opportunity to try something that seems daunting. And so I think anytime when you want to tackle a big goal, what somebody might think, oh, I've always wanted to write a chapter article, or I've always wanted to create a poster, and it seems insurmountable. The clinical ladder program provides people the opportunity to take those risks, but also be supported in it. And it seems sort of easier to tackle when you know that you have people around you who can give you the support to do it. But it also provides an opportunity for people to take those risks. I never would have tried to make a poster if I hadn't have been involved in the clinical ladder program. And I wouldn't have been involved in speaking to you guys if I hadn't been involved in the clinical ladder program. And it provides people the opportunity to step out of their comfort zone and tackle those big goals, and really put themselves out there in a way that is safe and supported and rewarded. And it's something we pride ourselves on in our department, and our clinical ladder participants are very proud of what they do and are very excited to share what they've learned and the skills they've gained. And we benefit from that. Our department benefits from that. And we're able to share that with other hospitals and other systems, and we can present projects and things that we've done and share them with other people so that they can learn and build on what we've been doing. So it's a great program to really support people and encourage exciting thinking and forward thinking in case management roles, and really get our names out there. And it also provides, one of the things I didn't talk about earlier was it allows us the opportunity to really promote case management in our hospital system. We have case managers who have projects that are involved with physician teams or resident teams or hospital systems. And so case managers can be involved in that change process because they tackled a goal that involved working with a attending physician on a project, or talking about case management, a case management interaction with a patient system, and seeing how that works within the hospital, with the physicians involved. So we can promote case management also from within and make sure that people understand how important case managers are and how important the work that we're doing is. And sometimes that is simply helped along by the fact that you had an idea in mind in terms of something that other people maybe missed. And it's a way to promote what we're doing so people see who we are and what we do. And then they can see it in the projects that we have, and the projects that we're supporting. And so bringing those up front.
It's a forum of innovation, right?
Absolutely.
It's a forum to allow folks to take those ideas and observations that they have clinically, and channel those in a way that's valuable for them as well as valuable for the organization.
Absolutely.
I love that. Yeah.
Yeah. And we can do that because we've given people the opportunity to find time to work on those projects and to really push themselves and to take those risks to challenge themselves and think about things in a different way. And sometimes the projects kind of don't end up the way that you thought they would. And even that is important to know. You might uncover something along the way that you never even thought was in play, just because you were investigating something further or looking at something in a different way. We've come up with lots of different alternatives to things, or things we needed to work on because people were working on a project that uncovered another need we had. So
I think that's important. Because
and we can also collaborate. Clinical ladder participants can work together on a project and share the point value. So, we've had people that have been able to work together in other departments or other service areas to join forces and create something together. So that's good too. It's encouraged us to be collaborative. We have outpatient case managers and we have inpatient case managers, so they can have projects together that help people through the transition process and hand off appropriately at discharge and work on ways to make sure that that is seamless. And so it really is an opportunity for so many things to be thought of in different ways, and like you said, to innovate new ways to look at things. And this provides that opportunity to do that in an exciting way.
That's great. Thanks, Kathleen.
Sure.
So you talked about that there is a financial or a compensation component to it, which I know people would be interested in. Can you talk at all just in terms of like other outcomes? So these projects or the professional progression for the folks you've just talked about, really going back for advanced degrees and that kind of thing. Anything that you've seen out of the folks that have participated that you think has directly impacted either your department where they've benefited or the hospital, just in terms of the projects that they're doing?
Yeah, we had, in fact, there's a poster presentation coming to the national conference this year of a clinical ladder project from two case managers who looked at readmission risks and had a system developed in terms of what discharged patients had a high risk of being admitted, and then had a rubric set up with what interventions could be given to those patients to try to keep them from being readmitted. We had two case managers who submitted a chapter article or an article in a journal. We've had people who did cost reductions in terms of trying to reduce length of stay. We've had people who volunteer in the community at community events and are helping, provide information about our services and other things our department does. So it can be anything that you want it to be, and we try to make sure that we don't limit people in terms of what they want to do, but also make sure that they're pushing themselves a little bit. And every year in May, during Nursing Month, we have one of our case management meetings is designated to showing people who passed their clinical ladder and talk a little bit about what their projects were and sharing those ideas with the department and letting people know what we did and hopefully get more people to join in for the next year. That's
great. So you're a highly experienced case manager. You've been doing it a long time, and I know you've talked about that as really a passion as well as your job. Just your perspective on the value of having this clinical ladder that wasn't in place as you started doing this work. So I'm just interested in your personal perspective.
Yeah, I think it was really, it's really something our department's very proud of, to listen to our case managers who clearly wanted something to do that would take the place of what clinical ladder programs they could be involved in when they were in a different department, and to really listen to the case managers and figure out what they wanted and how they wanted it to work, and to create that and then to put it into place. So that I think we're very proud as a department to share with people that we have a clinical ladder for our case managers. But it's also a group that's small enough that we also can provide feedback and let it change, and to help people make sure that it's working for them and it's about them, because really it ultimately comes down to how we're going to support the case managers and how we're going to make them feel rewarded and feel special and be encouraged to take those risks. And so while we do focus on outcomes for patients and the department and the hospital, and that's clearly part of it, the real goal was to make sure that our case managers were supported and felt that they were appreciated and their projects mean something, while also encouraging them to try to tackle really big ideas and really big projects. And this is a way to do it.
Yeah, have a vehicle for that.
Yeah. And, every year we add different, it's set up where there's a system of projects or programs you can be involved in, and they're assigned a point value. And so you have to get a certain number of points within that year, a smaller set of points for clinical or for case management 1, 2, and then a higher number for case manager 3. And so every year we try to add new projects and try to find new ways, because things kind of present themselves and things change, as we grow. The pandemic, taught us a lot about what we could do over, Zoom and over, electronic, means. And so we've had to kind of change to make sure that we moved with it and with the way things are moving in terms of our department. We needed to make sure that the ladder stayed in tune with how we were moving. And we can do that because on a base level, the case managers are the ones that we own what's going on in that ladder, even though the leadership makes the final decisions and they determine, the point values and all that stuff. They're really taking our feelings and our wishes into mind when they're making those decisions. They allow us the opportunity to really drive what we want.
That's great. Well, I'm going to assume there's going to be high interest. I've heard the questions come up about a clinical ladder. I think it's been a challenge to apply to case management. So
I really encourage anybody to, even if you're in a leadership role, I encourage people to look into doing that for your case managers. And if people are, want to be a part of something like this, to bring it to your management and share with them what you want to have happen and what you think could be possible, because it does take a lot of work. There's a lot of work that goes into it, but it's very rewarding. And we reviewed it in 2017, and then we just sent out a Qualtrics survey of our participants again to make sure that we were meeting the needs that they had in terms of being participants and making sure that it was still working for everybody, and everybody has wonderful things to say about it. So it's something we're really very proud of.
Well, congratulations on the work that's been done over, now it's been a lot of years, and I think a real investment in the practice and profession around case management. So thank you for that.
You're welcome.
As we wind up today, Kathleen, any final comment for our listeners?
No, I mean, I would just really appreciate people being interested in the concept and being interested in it as something that departments can do and something that's needed. I think it's a wonderful thing, and I've been involved. I was in the planning committee back in 2012, so it's just something I've really been passionate about, making sure that we try to get as many departments and as many case managers involved in clinical ladder programs, because I think it's just a really important thing. So I'm glad there's a lot of interest in it. I think it's exciting.
Well, that's great. And we thank you for being with us today.
Sure.
I really think sharing your experience and expertise is invaluable. So thank you for sharing about your innovative clinical ladder program. And again, questions, we have someone who's willing to answer those. Join thousands of your peers who have made the decision to further the connections, learning, and knowledge afforded through ACMA membership. Gain access to the Member Education Center, where you can access a multitude of recorded webinars, CEs, and peer-reviewed articles, all 24/7, available exclusively to ACMA members. Visit www.acmaweb.org/membership to learn more. For our listeners, let us know what you think of care transitions today. We encourage you to leave a review and rating and give us an idea of what topics you're interested in. Also, please be sure to subscribe so that you're alerted to when Our next episodes are released. And again, we're going to continue our series on innovation in our next episode. And until then, thank you for joining us today.